The topic of this video is shoulder joint, which is also known as glenohumeral joint. A long question is often asked in exams on shoulder joint, and the answer has to be written under the following headings. First is type and the subtype and the articular surfaces of the joint. Then attachment of the capsule and the ligaments that support the capsule and the joint, relations of the joint, and the movements that are possible at the joint along with the muscles which are responsible for producing those movements. And finally, the clinical anatomy or the applied anatomy related to the joint. You all must be knowing that shoulder joint is the most movable joint, but it is also prone to dislocation than any other joint. So here the stability is compromised for the sake of mobility. Let us look at the type of the joint. Shoulder joint is a ball and socket type of synovial joint. It is a multi-axial joint. Here the ball is formed by the round head of the humerus and the concavity of the glenoid cavity of scapula that forms the socket of this joint. Let us look at the articular surfaces. The articular surfaces are disproportionate to each other, and this is the reason for instability of this joint. So here we can see laterally the articular surface is formed by the head of the humerus, and this is larger as compared to the glenoid cavity, whereas the glenoid cavity of the scapula, this is not only smaller, it is very shallow also. So here again another thing that we can see here is that the articular surfaces are covered by this blue line which represents the articular cartilage, right? And that is hyaline cartilage. All synovial joints, with few exceptions, their articular surfaces are always covered by hyaline cartilage. The exceptions are the temporomandibular joint and the sternoclavicular joint. There the articular surfaces are covered by fibrocartilage and not hyaline cartilage. Now, as I said earlier, that the glenoid cavity is shallow, so it needs to be deepened. So there is a fibrocartilaginous ring which is attached to the margins of the glenoid cavity to make it a little deep, and this ring is known as glenoid labrums. This is fibrocartilaginous in nature. Coming to capsule of the shoulder joint, like any other synovial joint, it is going to enclose the whole of the joint from all the sides. But in this case, it is thin and it is lax, that is loose, because it has to allow wide range of movements. So we will first look at the attachment of the capsule on the humerus and then on the scapula. So laterally, the capsule is attached to the humerus, and where exactly it is attached? It is attached to the anatomical neck all along except inferior-medially, where it dips down or extends approximately 1.5 centimeter below the anatomical neck. It reaches the surgical neck of the humerus. So here it is very loose. So this here again, this is to allow more mobility. One more point of attachment of the capsule on the humerus is that it is deficient at one place, that is between the lesser tubercle and the greater tubercle. We can see there is a groove here, and this groove, actually in this groove lies the tendon of the biceps brachii. So 2 points we have to remember about the attachment of capsule on the humerus. First thing, it is attached all along anatomical neck except inferior-medially, where it extends 1.5 centimeter below the anatomical neck, reaches the surgical neck of the humerus. And second, there is a deficiency in the capsule between the lesser and the greater tubercle. Now let us see its attachment on the scapula. So medially it is attached to the scapula, and beyond the attachment of the margins of the glenoid cavity, in fact beyond the attachment of the glenoid labrum. Now if we see superiorly, the capsule is going to enclose a bony prominence which is known as the supraglenoid tubercle, which provides origin to the long head of biceps brachii. So origin of long head of biceps brachii, that is intracapsular, the tendon is going to run through the joint and will escape the joint through this deficiency in the capsule between the two tubercles, and then will be lodged here in the bicipital groove on the humerus. So let us look at the ligaments that support the joint, and these are: anteriorly we have 3 bands, and these are known as glenohumeral ligaments. So they are the superior, middle, and inferior glenohumeral ligaments. Superiorly we have another ligament here, and that is coracohumeral ligament. Now we had a deficiency in the capsule, so bridging that gap we have another ligament which is known as transverse humeral ligament. Now, if we see this coracohumeral ligament, this is going to extend from the base of the coracoid process till the greater tubercle, and it strengthens the capsule superiorly. Then glenohumeral ligaments we will see a little later, but let us first look at the transverse humeral ligament. This bridges the gap between the greater and the lesser tubercle, so it here supports the capsule. And the three glenohumeral ligaments, these three bands, they are going to strengthen the capsule anteriorly. Now, area between the superior and the middle glenohumeral ligament, this is a point of weakness, and this usually is the site of anterior dislocation of the shoulder joint. There are two accessory ligaments also which indirectly support it, and they are, here we can see this is the coracoid process, this bone is the clavicle, and here we have the acromion process. So first ligament is coracoclavicular ligament extending from coracoid process to the inferior surface of lateral 1/3 of clavicle. And another very important ligament here is from the coracoid process to the acromion process, and these three structures together, that is coracoid process, coracoacromial ligament and the acromion process, they form coracoacromial arch. Now let us look at the synovial membrane. Like any other synovial joint, so here also the capsule from inner aspect will be lined by the synovial membrane, which is going to produce the synovial fluid to lubricate the articular surfaces there. So here also you can see the dotted line. This is the synovial membrane. So this will be lining the capsule from the inside and also the non-articular parts of the bones. We can see here, right, the humerus, this part is also lined by the synovial membrane except the articular surfaces. Articular surfaces are never covered by the synovial membrane. Now let us see some specific features of the synovial membrane of shoulder joint, right? Now what happens here is that the synovial membrane from the capsule, here it is lining the capsule has been removed, and this is going to get reflected and will form a tubular sheath around the long head of biceps brachii. Remember that has intracapsular origin, and anteriorly, it will also extend through the anterior wall of the capsule and will become continuous with the bursa, which is present deep to the subscapularis muscle, and that bursa is known as subscapularis bursa. So these are the two modifications of the synovial membrane that can be seen, that it is forming a tubular sheath around the tendon of long head of biceps brachii, and second is it is continuous with the subscapularis bursa. We come to movements now. The movements, it is a multi-axial joint, so the movements will be possible across three planes, and they are flexion and extension, abduction and adduction, medial rotation and lateral rotation, and combining of these four movements, right, that forms circumduction. Okay, let us begin with the flexion. Now, in order to remember these muscles, you first look at this picture. In case of flexion, the arm is taken anteriorly, right? So you can put your hand on the upper part of the chest and the fingers on the upper part of the arm when the arm is by the side, that is in adducted position. Now take the arm forward against a little resistance, and you can feel contraction of certain muscles, and these muscles are where your palm is placed. There we have the clavicular head of pectoralis major, and then another muscle taking origin from clavicle going to humerus is the anterior fibers of the deltoid, and just below the lateral 1/3 of the clavicle you will feel the coracoid process, and from there two muscles are going to the anterior compartment of arm, and these two are biceps brachii and along with that coracobrachialis. So these are the four muscles which are responsible for flexion at the shoulder joint. So again, I'll repeat, the muscles are pectoralis major. The muscles have to be anteriorly placed, right? So they are pectoralis major, anterior fibers of the deltoid, and biceps brachii and coracobrachialis. What you have to remember? You just have to remember the muscles which are attached to the clavicle and to the coracoid process. They will be responsible for flexion at the shoulder joint. Coming to extension, you can see here the arm is taken posteriorly or backwards. So which muscles will be responsible? The muscles have to be placed posteriorly, right? So we have a big huge muscle on the posterior aspect of the trunk that is known as latissimus dorsi. So this muscle is going from the trunk to the humerus, right? So this is latissimus dorsi is the first one. Second, we have another muscle going from scapula to the humerus, again placed posteriorly. This is teres major. And then we have the posterior fibers of the deltoid. So these three are main muscles. They are responsible for extension. Triceps long head also helps in extension, but these are the three main muscles. So these are, where are these muscles placed? They are placed posteriorly. Which movement is involved? The movement is extension. That means taking the arm backwards or posteriorly. Therefore, posterior muscles, and the muscles are latissimus dorsi. Put your hand on the latissimus dorsi on the lower part of the trunk, teres major, and the posterior fibers of the deltoid. Feel that. That way you will remember it for a much longer. In fact, you will never forget it. If you visualize it or if you touch it, then you don't forget the things. Okay, so this is extension. Then we have abduction. Abduction is a slightly complex movement. So this is not only going to occur at the shoulder joint, but there will be rotation of the scapula also involved in this movement. So let us see here. We will divide this into two parts, right? Or three parts we can say, to make it simple, right? So it will be initiated. The beginning will occur, and that muscle which is responsible for 0 to 15 degree of abduction is supraspinatus. Deltoid cannot initiate, right? Because the pull is in different direction, right? The head is going to hit the coracoacromial arch, right? So it has to be slightly tilted away. The humerus has to be tilted away from the body first, and this can be done only by supraspinatus. So first 0 to 15 degree abduction is done by supraspinatus. Then most of the books will mention that from 15 to 90 degree will be done by the middle fibers of the deltoid, right? And above 90 degree, it is not possible without rotating the scapula. Otherwise, the greater tubercle of the humerus will hit the coracoacromial arch, right? So that's why, or the acromion process to be precise. So that's why the scapula has to be rotated laterally, right? It has to be, the glenoid cavity has to be tilted upwards. And this is done by the upper and the lower fibers of trapezius and serratus anterior. Now, how exactly abduction occurs? Let us see. For every 3 degree of abduction of the arm, that is at the shoulder joint, this is beyond the 15 degree. 2 degree abduction is going to occur at the shoulder joint where the deltoid is going to function, and 1 degree of abduction occurs by rotation of scapula where the upper and lower fibers of trapezius and the serratus anterior will be involved. We can see here how the upper fibers of the trapezius are pulling the lateral end of the scapula upwards, and these are the lower fibers of the trapezius working, and serratus anterior pulling the inferior angle forwards, right? So this will make the scapula rotate upwards or rotate it laterally. So actually, if this does not happen, then what will happen? Approximately around 120 degree of abduction, the greater tuberosity of the humerus that can come in contact with the acromion process if the scapula is not rotated. Therefore, elevation beyond 90 to 120 degree, we have to rotate the scapula laterally. So this you have to remember, that for every 3 degree of abduction beyond 15 degrees, 2 degree abduction occurs at the shoulder joint. 1 degree of abduction is possible because of the lateral rotation of scapula. The muscles responsible are supraspinatus 0 to 15 degree, then deltoid and upper lower fibers of trapezius and the serratus anterior. Sorry. Coming to adduction, this is there is a simple way to remember here. Now adduction, you can see here, it is taking the arm towards the trunk, right? So here again the muscles which will be responsible will be going from the trunk to the humerus. The way I used to remember is that these are the muscles which are attached on the bicipital groove, on the lateral lip, medial lip and the floor of the groove. Those three muscles, remember, the lady between two majors. And these are the pectoralis major, the latissimus dorsi and the teres major. So these are the three muscles going from trunk, because now the humerus has to be brought closer to the trunk. So you need two huge muscles which will be going from trunk, one anteriorly, another posteriorly, from the trunk to the humerus, and another muscle which is also doing the same thing is the teres major. So three muscles doing adduction, they are attached to the bicipital groove, their lips and to the floor, and they are pectoralis major, latissimus dorsi and teres major. Medial rotation. Now if you look at the medial rotation here, the elbow is semi-flexed and then taken medially, because otherwise you will also include the pronation. That's why it is shown like this. So medial rotation of the arm, the humerus is going to rotate medially. So which this thing will be responsible? One of the muscles of rotator cuff, that is subscapularis, which is placed anteriorly. So that is the first muscle, right? This is involved in medial rotation. Then what else? Which muscles will be there? Then we will have the pectoralis major, the latissimus dorsi and anterior fibers of deltoid. You have to remember that the anterior fibers of deltoid, they will be responsible for flexion and for medial rotation, right? Posterior fibers of deltoid, they will be responsible for extension and lateral rotation. And the middle fibers will be responsible for abduction. So this is involved in all the movements. Deltoid is involved in all the movements except adduction, right? So I'll repeat, the muscles for the medial rotation, they will be subscapularis, right? So this is the muscle which is attached to the lesser tubercle, which is closer to the trunk, right? So which is more medially placed. So this muscle is the subscapularis. Then we have pectoralis major. Then we have anterior fibers of deltoid and the latissimus dorsi. Coming to lateral. Okay, so muscles responsible for lateral rotation. Now here you can see the elbow is semi-flexed and the hand is taken outwards, right? So this is the lateral rotation at shoulder joint, and the muscles responsible would be now two muscles of the rotator cuff or musculotendinous cuff. Those muscles are infraspinatus and teres minor. Now for rotation at any joint, the muscles actually should be inserted and they should take origin very close to the joint. So that's why the musculotendinous cuff muscle, they are involved in rotation. Subscapularis in medial rotation and infraspinatus and teres minor, which are attached to the greater tubercle, right, which is laterally placed. So they will move the humerus laterally. So these two muscles will be responsible for lateral rotation, and then we have the posterior fibers of deltoid. So these muscles will be responsible for lateral rotation. For circumduction, here we will see that actually this is a combination of various movements. What happens here is the distal end of the humerus moves in circular motion as if you are bowling in cricket, right? And this is performed successively by the following movements, that is flexion, then abduction, extension and adduction, right? So this is known as circumduction. Now let us look at the relations of the shoulder joint. So here we are going to see the superior relations, the inferior relations, the anterior relations and the posterior relations. So let us start with the superior relations. So you have to now visualize. In anatomy, if you want to remember things for long time, although they say that anatomy is memorization, I don't accept that. Memory is actually, anatomy is a visual subject. So you have to visualize in your body. Everything is there in your body, right? And that's why we say that atlases are a must. Okay, so here also visualize your own shoulder joint, right? And think which structures would be present above that. So starting with the first muscle that will be present just above the shoulder joint, that will be the supraspinatus. Now there is a bursa, right? We can see here there is a bursa above that, and this bursa is known as subacromial bursa. Sometimes it is very big and extends deep to the deltoid also. Then this bursa is known as subdeltoid bursa also. So this bursa becomes very important for the smooth movement of the supraspinatus. Otherwise, it is going to rub against the coracoacromial arch. Okay, so the first structure superiorly is the supraspinatus tendon. I hope you are visualizing that. And then there is a bursa, right? The sac of the synovial sheath, you can say that they are lubricating structure. And then after that, what will we have? We'll have coracoacromial arch, or you can see coracoacromial ligament would be there. And then finally above that will be the deltoid muscle, right? So these are the structures which will be present on the superior aspect, supraspinatus. Then we have the subacromial bursa, we have coracoacromial ligament, and the uppermost structure has to be deltoid. Next, let us see, okay, this is just to tell you the structures which will be within the joint, obviously would be the tendon of the biceps brachii. We have already seen that. So let us see the structures which will be present anteriorly. So anteriorly, if you see again, let us see here, the first muscle would be closest to it would be the subscapularis, right? So the closest muscle, right, superiorly, anteriorly and posteriorly, they have to be the rotator cuff muscles, right? And the outermost or the most superficial muscle which will be coming in relation to the shoulder joint anteriorly, superiorly and posteriorly has to be deltoid. So first of all, remember this, okay? So superiorly, which muscle of the musculotendinous of cuff was present or rotator cuff? Supraspinatus. Anteriorly would be the subscapularis. And then anteriorly we have the coracoid process. So two muscles taking origin from coracoid process are short head of biceps brachii and coracobrachialis. So they will come in relation anteriorly. And which muscle I told you superficial would be there? That would be the deltoid muscle, right? So these are anterior relation. Subscapularis, then muscles attached to coracoid process, that is short head of biceps, then coracobrachialis, and then we have the deltoid, right? So anterior fibers of deltoid would be there. Now let us see the structures which will be present posteriorly. Again, remember the deepest structure would be the musculotendinous cuff muscles. And which two muscles are left now? Infraspinatus above and teres minor below. And which muscle will be covering them? Deltoid. Is this simple now? So superiorly you have the supraspinatus, anteriorly you have the subscapularis, posteriorly you have infraspinatus and the teres minor. Superiorly, between the deltoid and the supraspinatus, you have two structures, and these are the subacromial bursa and coracoacromial ligament. Anteriorly also, between the deltoid and the subscapularis, you have two muscles, and these are the short head of biceps and the coracobrachialis. But posteriorly, there is nothing between the muscles of the musculotendinous cuff and deltoid, right? So infraspinatus, teres minor and deltoid. Coming inferiorly, the joint is not supported by the musculotendinous cuff muscle, so they won't be there. But from infraglenoid tubercle of the scapula, a muscle takes origin. So that will be placed inferiorly, and that muscle is the long head of triceps. Now there is a nerve and vessels which come in relation to the surgical neck of the humerus, and they are axillary nerve and posterior circumflex humeral vessels. So these are the structures that will be coming in relation to the shoulder joint inferiorly. The three structures are long head of triceps brachii, axillary nerve, yellow color, and the vessels are posterior circumflex humeral vessels. So this way the relations become very, very simple. Okay. Now arteries supplying the arteries which are present around it, right? So on the posterior aspect you have the suprascapular artery. Then we have close to the surgical neck, around that surgical neck we have anterior and posterior circumflex humeral arteries, and there is another artery that is subscapular artery. These are branches of axillary artery. So just remember, we just have to remember the arteries. How will you remember? The bones which are participating are the scapula and the humerus. So two arteries which are supplying the scapula but on the lateral side. So these are suprascapular from above and subscapular below. And on the humerus, those arteries which are encircling the surgical neck of the humerus, because the arteries have to be very close to the joint, and they are anterior and posterior circumflex humeral arteries. So that's how you can remember the arteries supplying. Coming to nerves. The nerves, again, they have to be close to the joint and they should be supplying the muscle or the area of the skin over that. Hilton's law is there and they are crossing this joint. They are suprascapular nerve, axillary nerve, and the musculocutaneous nerve. So these are the three nerves. Suprascapular, scapular side mein, then axillary, surgical neck mein. Another one which is close there is the musculocutaneous nerve. These nerves supply. Last is the clinical anatomy of the shoulder joint. Let us see here. Now, inferior dislocation of shoulder joint is common. Why is it common? This can be asked, right? Why? Because I have already told you repeatedly, the capsule descends downwards by 1.5 centimeter onto the surgical neck of the humerus and it is very loose here. Second point is that the capsule here does not get supported by any muscle of the musculotendinous cuff. We can see here the muscles of the musculotendinous cuff, they are supporting. We don't even have any ligament also here, right? So the muscles are anteriorly subscapularis, above supraspinatus, and posteriorly teres minor and infraspinatus. But there is no muscle which can support here inferiorly, right? So that's why the inferior dislocation of shoulder joint is common. Now what happens? Following inferior dislocation of shoulder joint, it is found that the patient, you can see the rounded contour of the shoulder that is lost, and there is weakness in one of the movement, and that is abduction of arm. If you see which muscle forms the roundedness of the shoulder, that is deltoid. Which muscle is involved in abduction? That is also deltoid, right? So what happens to deltoid when there is inferior dislocation? What happens in inferior dislocation? The nerve which is related to the surgical neck of the humerus, that is axillary nerve, that may get injured, and as a result there will be paralysis of the deltoid muscle, and that's why the rounded contour of the shoulder that will be lost, and plus there will be weakness in the movement of abduction. So beyond that, right, what else will be seen in this patient? The axillary nerve by its cutaneous branch that supplies the skin over the lower half of the deltoid. This is known as the regimental badge area. The forces people, they put their badges here. You must have seen a colored patch is put here, right? So there also there will be sensory loss. So this is somewhere here. This is the deltoid. So here on the lateral aspect of the deltoid, in it, the skin over its lower part, there the sensory innervation or sensory loss would be also there. Now another condition, frozen shoulder. Now this frozen shoulder is characterized by pain and loss of movement or stiffness in the shoulder. Now this can develop after a shoulder is immobilized for a certain period of time, right, because of some disease there. And what happens exactly here is thickening and contracture of the capsule, right? So the capsule fibers, they undergo contracture, and thickening also occurs. Adherence of the synovial membrane, there will be adherence between the synovial membrane and which surround the joint. That's why it leads to frozen shoulder. Frozen shoulder means the shoulder cannot be moved, right? So that is freely. That is the known as frozen shoulder, right? Another condition which is supraspinatus tendinitis, or so here you can see inflammation of the tendon of supraspinatus, or there can be subacromial bursitis, inflammation of the subacromial bursa which is present just above that. This is also known as impingement syndrome, and some people also call it painful arc syndrome. So what is this? This usually occurs in old people, and what happens is when the abduction is initiated, at that time also the pain is not there, but pain is felt between 60 to 120 degree of abduction. Why at this time? Because at this time what happens when the arm is taken upwards, the inflamed tendon of supraspinatus, that is in case of supraspinatus tendinitis, or inflamed subacromial bursa, in case of subacromial bursitis, they press against the coracoacromial arch, and because of that the patient feels pain. Thank you so much for watching. I hope you have liked the video.